My name is Sandra. I am an M2 at the University of Buffalo, and I will be discussing the use of 5-ALA, aminoluluvinic acid, for the resection of high-grade glioma. And this is the result of a clinical trial that was conducted in 2006 and published in Lancet Oncology. And this is the citation for reference. And here's a picture of myself and my family. And I have no conflicts of interest. So as we've been discussing over the past couple of weeks, malignant high-grade gliomas are locally invasive brain tumors that have a poor prognosis for the patient. And as you can see in this table, the median survival for patients with, say, a type 4 glioblastoma is 15 months with a 27% two-year survival. And these tumors, we have about 10,000 new cases of glioblastoma every year in the US, and worldwide 238,000 new cases of brain tumor with 174 deaths annually. So this is a condition that impacts a lot of people. And as we've been also discussing, the treatment for high-grade glioma consists of maximum cytoreduction or resection of the tumor, followed by radiation therapy and adjuvant temozolomide chemotherapy. And so prior to 2006, or around the time that the study was published, fewer than 20% of patients were able to, surgeons were able to get maximum cytoreduction of contrast-enhancing tumor in fewer than 20% of patients. And the reason that was cited is difficulty in defining the margins of the tumor. And some of the modalities that surgeons had to define the margins of tumors included intraoperative MRI, neuronavigation, ultrasound, and fluorescent dye. And the only modality that was studied was MRI, and the study found that there was no benefit as far as tumor resection when MRI was used. And there are also several problems with using these modalities intraoperatively. And so none of these methods were regarded as standard for use in malignant glioma resection at the time. And like we've also been discussing today, like why is this even important? And this is because there's a survival benefit that's associated with complete reduction of the tumor. And this benefit was compounded as this clinical trial found that for patients who had complete resection, there was an additional benefit, or these patients received the most benefit from temozolomide regimen as compared to patients who had had incomplete resection. And for patients, disease progression marks a burdening treatment time for the patient. This means that they have to have additional chemotherapy or repeat surgery. And the paper cited that clinical experience shows that there's a correlation between radiological progression of a tumor and clinical deterioration for the patient. And this really was the basis of this study. They wanted to see, or they wanted to analyze, see if the use of 5-ALA was able to help in visualization of the tumor. And so you ask the question, what is 5-ALA? It's a natural biochemical precursor of hemoglobin that leads the synthesis and accumulation of fluorescent porphyrins in epithelial and cancerous tumor, but specifically in malignant glioma. And unlike other fluorescent agents that have to penetrate the defective blood-brain barrier, 5-ALA is not reliant on the blood-brain barrier to accumulate within the glioma. And this clinical trial wanted to assess the effect of fluorescence-guided resection with 5-ALA on surgical radicality, progression-free survival, and overall survival and morbidity. And so while this slide is a bit busy, it just shows the overall methodology of the study. So they enrolled 322 patients at 32 investigators at 17 German centers from 1999 to 2004. And the patients were followed for a median of 35 months. And Patients were identified using the criteria that they had a distinct ring-like pattern of contrast enhancement on MRI with irregular walls. And there was also a reduced signal that suggested a necrotic center in the tumor. Patients were also evaluated for exclusion criteria. And one of the exclusion criteria that I want to mention is that the tumor location did not enable complete resection. So if the tumor was located in a region where complete resection was not possible, those patients were removed from the study. And they were both randomized into two groups, one being patients who received ALA, and this was given as 20 milligrams per kilo prior to surgery, and this was oral formulation, versus the control group that used conventional microsurgery with white light and a traditional uh, uh, fluorescent dye like fluorescein. Patients received Decadron prior to surgery, and this was in both groups, and they had they followed a stop protocol postoperatively. And this means that the patients, both groups got radiation of maximum dose 60 guys given at 2 guy increments over 6 weeks. And however, patients who had cancers that were susceptible to chemotherapy were allowed to get chemotherapy prior. And once the tumor resurged, patients were not restricted from receiving chemotherapy. Data was collected at different time points, and the study needed in its initial design about 350 patients to achieve 80% power. And an interim analysis was scheduled at 270 patients. At 270 patients, the study did an analysis that showed that there was a statistically significant difference between the two groups, and this was achieved at 80% power, and so the trial was ended at that point. So if you look at this diagram, it shows the two arms, and it shows like the characteristics of patients in both arms, and they were randomized such that they were distributed equally by age, Kanofsky Performance Scale, which is an evaluation that can be done that indicates the prognosis of a patient that's diagnosed with a glioma. Tumor location, that is the tumor located around an eloquent or non-eloquent area in the brain, with the eloquent areas being areas that control either motor function, sensory modalities, or cognitive function in the brain. And also patients, after pathological analysis was done of the tumors, the patients were randomized such that they had fairly equal characteristics in the cancerous tumor size. The study was designed such that patients were randomized prior to the surgery. And so after the resection was completed, samples were sent to pathology, and some patients were eliminated from the study at that point. It's important to note that 261 out of the 270 patients had a grade 4 WHO grade 4 lesion, and 237 of the patients had a GBM. These are the primary endpoints of the study. So the first endpoint was what proportion of patients had histologically confirmed malignant glioma on central neuropathological review without residual contrast enhancing tumor and postoperative MRI. And this MRI was completed within 72 hours after surgery. The second primary endpoint was progression-free survival at 6 months. Secondary endpoints included residual tumor volume on post-op MRI, overall survival, and the type and severity of neurological deficits after surgery, and also what are the toxic effects of ALA. In result, they found that more patients assigned to ALA were without residual contrast-enhancing tumor on early MRI as compared to those with white light, and this difference was 29%. On this table, you can see that 90 out of the 139 patients who were assigned in the ALA group were without residual tumor on postoperative MRI as compared to 47 out of 131 with white light. When progression-free survival at 6 months was compared, it was higher for patients with ALA as opposed to those with white light. And the difference between these groups was 19.9%. So that was very significant, very significant. As you can see in this graph here, it shows the progression-free survival for the white light group as opposed to the ALA group. And I just want to point out at the bottom of the table, it shows numbers at risk. So as the study progressed over time, you had less patients that remained in each arm of the study. But as you can see, there are more patients in the ALA group than in the white light. But the study was not powered to detect overall survival, and it was not designed to do so. But I point this out to note that progression-free survival is graphed as a percentage of the total patients. And for the patients with white light, the median progression-free survival was 3.6 months as opposed to 5.1 months in the ALA group. And so the patients with ALA, they took longer for their tumors to progress. When subgroups were analyzed, they found that this 6-month progression-free survival was found in patients that were older than 55. They had a Kanofsky performance scale that was greater than 80. And in both areas where the tumor was close to an eloquent area and where it was not. And this benefit was not found in patients 55 or younger with a Kanofsky scale between 70 and 80. So if we go back to the primary and secondary objectives of the study, when you ask the question, was there any residual tumor on postoperative MRI? For both groups, they found that residual tumor was small. And however, the median volume was significantly smaller in the ALA group as opposed to those in white light. For progression-free survival at 6 months, this again was higher. It was higher with patients with ALA as opposed to those with white light. The severity and type of neurological deficit after surgery, when post-operative Kanofsky performance score, neurological status, and toxic effects were compared, they were much the same for both groups, and this indicated that ALA was safe. This study had some limitations, and the one being that it was not powered to detect overall survival, and there was some inconsistency in intraoperative diagnostic procedures. And this means that surgeons were allowed to use any modality that they saw fit to plan the initial surgical approach, as well as localize the tumor once they began the surgery. But they were only allowed to use either ALA or standard fluorescence, white light, to localize the margins of the tumor. There was a mixture of grade 3 and grade 4 tumors, and the STEL protocol was slightly inconsistent with patients, with some patients allowed to have chemotherapy earlier than others. So it is possible that these limitations might have introduced some bias into the results, and further studies were needed to address these limitations. But in conclusion, high-grade gliomas are very invasive tumors, and they do have a poor prognosis for patient. Complete tumor resection is essential because it does provide clinical benefit for patient, and this benefit is additional. It's an additional benefit to the adjuvant radiotherapy and temozolomide regimen. And ALA did provide a clinical benefit for patients on removal of tumors.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.